Welcome to today's webinar, Increasing Burden and Complexity of Multimorbidity in Two Index Conditions, Heart Failure and Dementia. This webinar series is coordinated by the Aging Initiative, which is an NIA-funded initiative that brings the expertise and leadership of two powerhouses for research on multiple chronic conditions. The two powerhouses are the Healthcare Systems Research Network and the Claude D. Older Americans Independent Centers, or PEPPER Centers. The Aging Initiative is led by Dr. Jerry Gurwitz at the University of Massachusetts and Myers Primary Care Institute, along with co-PIs Elise Adams and Jay Magaziner. My name is Heather Whitson. I'm an Associate Professor of Medicine and Ophthalmology and the Deputy Director of the Duke Aging Center, and I'm part of the Aging Initiative Dissemination Workgroup, which is co-led by Leah Hanson at HealthPartners. So before we get started, I just need to cover a few technical details. Due to the number of registrants for today's webinar, we have placed phone lines on mute to reduce audio feedback. So unless you are logged in as a host or a panelist, your line is muted. However, we welcome and encourage audience participation using the Q&A and chat features of the webinar software. So if you're in your Cisco webinar portal, you should look at the row of circles across the bottom center of the screen. And if you click on the chat bubble icon, it will be highlighted blue. If you have questions for our speakers, please click on the Q&A tab on the right side of the screen, and you can type into the Q&A box. Leah and I will keep an eye out for those questions under the Q&A icon, and as time permits, we will read questions for the speakers after the presentation. If you have technical or logistical questions, we ask that you submit those using the chat box that is above the Q&A box. Please make sure that you're identified either by name or participant ID so that our webinar hosts will be able to help troubleshoot any problem that you could be having with audio or other issues. So with the chat function, you can choose whether you'd like your comment to be visible to all participants, or you can choose to send the question only to the hosts. We would like to extend a huge thanks to Catherine Anzoni and also Chris DeLude at the Myers Primary Care Institute. They do amazing work behind the scenes to make these webinars possible. They'll be monitoring the chat functions today and will be helping with any technical troubleshooting. And now I'd like to introduce today's speakers. So first, we will be hearing from Mayra Tisminetzky. She is an assistant professor in the Division of Geriatric Medicine at the University of Massachusetts Medical School and holds a secondary faculty appointment in the Department of Quantitative Health Sciences at UMMS. Her research focuses on multimorbidity assessment, clinical management of patients who are hospitalized with a cardiovascular disorder and multimorbidity, and identifying innovative methods to investigate the association of multiple chronic conditions with clinically relevant outcomes. Next, we will hear from Dr. Ariel Green. Dr. Green is a geriatrician and assistant professor of medicine at Johns Hopkins University School of Medicine. Her research focuses on reducing use of potentially harmful medications in older adults, particularly people with dementia, and improving communication and shared decision-making between patients, family caregivers, and clinicians. Thank you to both Mayra and Ariel for their presentations. And with that, I'm going to turn it over to Mayra to get started.
Thank you, Heather. And can you hear me now?
Yes, we can hear you.
Perfect. So, sorry, I thought, okay. Okay, so first of all, thank you to everyone for being in this webinar, and thank you for the opportunity to the Aging Initiative to give me the opportunity to present my pilot work for this initiative. So I'm going to start here. Okay, so as you know, I mean, multiple chronic conditions are very prevalent in everyone, especially in the older population. And as was stated by Mayra Tisminetzky and her group, the most common chronic condition experienced by older adults is multimorbidity, and that means the coexistence of multiple chronic conditions or diseases at the same time. So why is also important, besides being very common and very prevalent, to study multiple chronic conditions? This has to do with the majority of the care used by everyone in the U.S. is used by individuals that have 2 or more chronic conditions. And also multimorbidity has been shown to be highly associated with a high risk of hospitalizations and death, especially in older adults and in individuals with heart failure. A little bit more of background. Also, patients with heart failure are a very important challenge for healthcare providers because we are dealing not just with treating patients with heart failure, but treating these multiple chronic conditions. And unfortunately, there is not much information out there about how to deal with these challenges of treating multiple chronic conditions. And usually, older adults with multiple chronic conditions are excluded from RCTs, from clinical trials, and there is also not much information out there in guidelines about how to treat these individuals and how to deal with the challenge of dealing with the interaction between medications and the conditions, the interaction between conditions and the interaction between medications. So it's a very important issue and has a lot of challenges, and it's, very appealing to me at least. Sorry, I think I skipped one of, that's okay. Okay, so a little bit of background about heart failure for those that don't have a clinical background. So what it means to have heart failure means that basically that the heart cannot keep up with the workload, meaning that, the heart muscle is unable to pump enough blood to meet the body needs for blood and oxygen. And based on the American Heart Association latest classification, there are 3 types of heart failure. Those are preserved, borderline, and reduced, and they have to do with the amount of blood that the heart can pump and just meet the needs of the body. And for this special pilot study, we are going to look into the 3 different types and compare outcomes in the individuals that have the different types of heart failure. And for this pilot study, we also validated the heart failure type, and we use echocardiography just to measure the ejection fraction and give the different individuals a place in the heart failure type. So the overall aim for my pilot study was to assess multimorbidity burden and association with clinical outcomes in individuals according to age, sex, and heart failure type. And the clinical outcomes that we're going to look into are heart failure related and any cause hospitalizations and all cause mortality. So in order to answer the questions that we have for this pilot study, we have source population that comes from the Cardiovascular Research Network, and basically there are 5 sites that we're using for this specific pilot study, and the 5 sites are Kaiser Permanente, Colorado, Northwest, Northern California, Southern California, and Fallon. And for those that are not very familiar with the system, with the Cardiovascular Research Network, each of these sites have a virtual data warehouse, and in each of these sites and warehouse, we collect electronic data sets with information with demographic characteristics, ambulatory pharmacy, outpatient lab tests, and healthcare utilization. So for this particular study, we are using data from individuals that are part of the Cardiovascular Research Network and were part of the system between 2005 and 2012. And we have follow-up data up to 2013. So we try to keep as close to clinical practice as possible. So we included all individuals that were 21 years and older and were hospitalized with a diagnosis of heart failure. And we tried to include as much as possible of all the population. So we only excluded very few patients that were, died on the index date or they were disenrolled. So we ended up with a large sample of patients, adults with heart failure, that were 553 patients. So just a very brief description. I mean, it was a retrospective study that happened between 2005 and 2012. And as I mentioned before, just being 21 years old, I have a diagnosis of heart failure, and being part of the system was enough for the inclusion criteria. Regarding the multimorbidity burden measurement, we included in our study 26 chronic conditions that were identified using ICD-9 codes attached to the encounters. So if we look for the ICD-9 codes for inpatient, emergency, ambulatory diagnosis, and procedures found in the virtual data warehouse. All these conditions were summed for each study subject, and we created a multimorbidity count. And then, based on the distribution of the study sample, we stratify the population on quartiles, and we have 4 comparison groups based on the burden of multimorbidity. So regarding the outcomes, as I mentioned before, we look into hospitalizations and death. Hospitalizations could be for any cause or could be heart failure related. And we got this information from, again, the virtual data house, and the admissions for heart failure were based on primary discharge for heart failure using ICD-9 codes, and deaths were identified from hospital and billing claims, and also administrative health plan databases that state death certificates and Social Security Administration files. So some of the characteristics of the study sample, I mean, the median age of this group was 75, and we have a nice and good representation of the different age groups. And also, I wanted to highlight that, I mean, almost 20% of our population were 85 and older, and we have a good representation also of ethnicities and different races. We have around 11% of Black African Americans and 13% of Hispanics. And as you can imagine, I mean, this is a very kind of sick population, so the median morbidity count was 6 for this population. So this is just some of the conditions that we look into. I mean, it's a long list of 26, but this is just some of the conditions that we look at. And as you can see, I mean, and as expected, I mean, they have hypertension, they have diabetes, very high prevalence, but also we look into other conditions or other things that we thought were interesting, like visual impairment, hearing impairment, mobility impairment, and other conditions. So we have a good representation of a large variety of chronic conditions. So they also, just to show you that these patients have, I mean, we're taking a lot of medications, and this making the point that, again, there were also, I mean, not only connections between the different conditions, but also between conditions and medications, because, I mean, a huge, I mean, amount of patients were receiving different medications. Okay, and this is just to show you, I mean, the distribution of counts of multiple chronic conditions. I mean, the range went from 0 to up to 18 conditions. And as you can see, I mean, they have a very high prevalence of different chronic conditions. So based on this, we decided to stratify or divide our population in 4 groups based on the distribution of these conditions. And we have patients that have 0 to 4 conditions, patients that have 5 to 6, 7 to 8, and then 9 plus. And we try to divide these groups just to make numbers that make sense and also enable us to do comparisons further up. So these are the 4 groups that we have, and you can see, I mean, they were large groups, and we try to make numbers pretty similar between the groups to allow us to be comparable and able to make the analysis. So in order to see then the outcomes now, as you can see, and as it can be expected, I mean, the more conditions you have or the higher burden is of comorbidities, the worse are your outcomes. So, for instance, for when we're examining the age groups, we can see that, I mean, the different age groups and the burden of conditions with every of the three outcomes. And you can see there is a prominent effect in the younger groups. So meaning that the more conditions you have when you're younger, the higher is your risk of all the three outcomes, all-cause mortality, heart failure-related hospitalizations, and any cause of hospitalizations. And all these models were adjusted for demographics, lab tests, physiological variables, medications, and study site. So this is for the age groups, for the different age groups, and now we can also see how the outcomes vary for men and women. And it's as expected, or as you can see here, I mean, the more conditions you have, the higher is the risk of having the adverse events. And actually, there is not much difference between men and women, and you can see the same patterns for all the three outcomes. And then for heart failure type, the same. I mean, the more conditions you have, the higher is your risk of having the adverse events. And there's also not much difference between the three types of heart failure. So they are pretty consistent, and the trends are pretty similar for the three types of heart failure type. So in summary, as you can see, I mean, increasing risk of adverse clinical outcomes is, I mean, increased with the burden of multimorbidity, and similar trends were found in men and women across the different age groups and in those with preserved, reduced, and borderline ejection fraction. And we saw a prominent effect in those individuals that were 65 or younger. So some strengths about the study is like the community-based study with a broad geographic, socioeconomic, diverse cohort. There are some limitations, as all the studies, like the lack of information on severity of disease and time from diagnosis. And we didn't have also the cause of death data for this study. So in conclusion, this is a large observational study using a very simple analytical approach, summing just the number of chronic conditions, and this can help us to identify important high-risk groups of people, or patients with heart failure, that can allow us to design future randomized clinical trials, and then maybe try to give more relevance to patients that are at higher risk of adverse outcomes. And the findings of this study, this pilot study, were just recently published in the Journal of American Geriatric Association. And so I think that's it. Yeah, so I also wanted to say thank you to all my collaborators and to all the HCSRN-OAICs Aging Initiative group and my mentors and collaborators for the study. And I think that's it for me. Thank you.
Thank you, Mayra. And again, I'll remind everyone, as Ariel is pulling up her slides, that if you would like to ask questions, please use your Q&A function, and at the end of the presentations, we will read questions for both of our speakers. And Ariel, I can see your slides now, so I'm going to hand it over to you.
All right, can everyone hear me okay?
Yes, we can hear you.
Okay, great.
Thank you.
Thank you so much for giving me the opportunity to present my work. So we've just heard from Mayra about how multimorbidity negatively impacts outcomes for people with heart failure. And now we're going to switch gears just a little bit and talk about multimorbidity in older adults with cognitive impairment or dementia. So In contrast to Mayra's study, the study I'm going to tell you about investigates how multimorbidity affects the care of people with cognitive impairment and dementia on a more granular level, so drilling down to what discussions about medication use actually look like during primary care visits for these patients. So I have no disclosures, and my research is supported by grants from the NIA. So to illustrate this topic, I'd like to start out by telling you about a patient I saw recently in our geriatrics clinic. So Mrs. R is 82 years old. She's a retired teacher and is widowed, and she lives in a continuing care retirement community. Her two sons each live about an hour and a half away. And on her, on her first visit, she and her son explained that she used to enjoy things like playing bridge and walking her dog, but she's become increasingly socially isolated. And this was the list of concerns that they prioritized that day. So her increasingly clouded cognition and anxiety, her frequent falls, dry mouth, urinary incontinence, macular degeneration. She was particularly concerned with her polypharmacy, and then her son brought up concerns about her lower extremity edema, heart failure, and atrial fibrillation because of the medications that she had to take for these conditions. She also had multiple doctors and poor continuity of care, and her mini-mental score on that visit was 23 out of 30. So these were Mrs. R's medications, which her son actually brought to the visit in a large plastic storage bin. So as you can see, she was taking amiodarone, apixaban, metoprolol, losartan, atorvastatin, and furosemide for her cardiac conditions. She had a potassium supplement. She took solifenacin for her urinary incontinence, buspirone and lorazepam for her anxiety, and then she had calcium and vitamin D, an eye vitamin supplement for her macular degeneration, fish oil, and she received annual zoledronic acid infusions. So like Mrs. R, we know that the majority of people with dementia have 3 or more chronic conditions in addition to their dementia. And although older adults with dementia have an average life expectancy of 2 to 8 years and are unlikely to experience benefits of interventions that have a long lag time to accrue, we also know that de-intensification of medical therapies, including medications, is rare. So, for example, although the benefits of type glycemic control and type 2 diabetes take years to accrue, and despite the elevated risk of hypoglycemia, especially in older diabetic patients with dementia, one study found that among veterans with diabetes and dementia, 52% were taking multiple medicines, including sulfonylureas and insulin, to achieve tight control of their diabetes. Another study found that 1 in 6 nursing home residents with advanced dementia, which was defined for that study as severe impairment with eating problems, they were prescribed a statin at the time of progression to advanced dementia, and most continued the statin on follow-up. So for clinicians, prescribing decisions for people with dementia and multimorbidity or multiple chronic conditions is challenging. So, like Mrs. R, most people with dementia take 5 to 10 medicines on average, of which 1 to 2 of these are for the dementia itself, and the rest are for their other chronic conditions. Dementia plus other chronic conditions puts people at risk for polypharmacy as well as potentially inappropriate medicine use in which the risks outweigh the benefits. And both polypharmacy and potentially inappropriate medication use are associated with increased risk of adverse drug events, hospitalization, and mortality in these patients. So optimizing prescribing for people with dementia means putting them on just right medication regimens, so minimizing potential harms while continuing to treat conditions that will help them achieve their goals like improved quality of life and functional status. So little is known about how best to communicate and foster informed decision-making about medication use in people with cognitive impairment and dementia. And so we wanted to get a clear picture of what communication about medications currently looks like during primary care encounters for older adults with cognitive impairment and dementia in order to lay the groundwork for developing practical communication strategies. So we did a qualitative content analysis of audio-recorded clinical encounters from the same page trial. This was a randomized pilot trial of a patient and family agenda-setting checklist for patients with cognitive impairment in primary care. So the trial did not intervene upon clinicians, and it was not focused on medications. So its objective was to get the patient and caregiver to agree on an agenda for the visit. So they completed a checklist to agree on an agenda while they were sitting in the waiting room. There were 93 patient-caregiver dyads at 2 primary care clinics and 1 hospital-based geriatrics clinic in Baltimore. And all 93 visits were audio recorded and transcribed, and we did our qualitative analysis of all of these visits, so intervention and control patients. And then to be included in the study, people had to be 65 or older and have at least 1 incorrect answer on a cognitive screener. And they also had to attend medical visits with either a family member or an unpaid companion. And just briefly, the demographics of the same page participants. The average age was about 80. Just over half were female. 42% were either non-white or Hispanic. 47% had beyond a high school education. The average mini-mental score was 22, and about a quarter were taking 10 or more prescription medicines. Also, as we might expect, most of the visit companions were female and were either spouses or adult children. So our results clustered into 3 major themes with associated sub-themes. So these themes were clinician strategies for discussing optimal prescribing, clinician strategies for facilitating patient-caregiver engagement in medication decisions, and finally, factors complicating optimal prescribing. So first, I'm going to talk about clinician strategies for discussing optimal prescribing. So we found many examples in which clinicians introduced patients and caregivers to key concepts of optimal prescribing for older adults with cognitive impairment. So clinicians often laid the groundwork for conversations about deprescribing by explaining that a person's needs and the balance of benefits and harms of a medication may change with aging and dementia. They also talked about scaling back or de-intensifying certain medical interventions, including medications, in order to avoid treatment burden and side effects and improve function and quality of life. They reframed patients' expectations about the limitations of medications, that medications can't always completely fix every symptom. They also explicitly addressed the uncertainty of the evidence applicable to older adults with multiple chronic conditions as well as cognitive impairment. And then finally, they introduced the idea of diminishing returns, or, for example, that when there are many ways to prevent a stroke, each additional intervention is associated with smaller and smaller benefits and exponentially increasing harms. So for the sake of time, I'm going to illustrate 3 of these sub-themes or strategies with representative quotes. So these are some of the encounters we found in which the discussions about deprescribing seemed to go particularly smoothly and patients and caregivers responded positively. So first of all, symptoms cannot always be fixed with a medication. So in this example, the clinician is adjusting the patient's expectation and explaining this concept. So the patient has asked to increase his tamsulosin dose because of nocturia, and the clinician says, well, there's always simple things we can do instead, like eliminating your fluid intake in the evening. And the patient says, oh, it's like the discussions we've had before about you're growing older and there are things happening to your body. And the clinician says, right, there's no easy answer, but part of the flip side is that in medicine we want to do no harm. So in this next example, the clinician is introducing the patient and caregiver to the idea that the balance of benefits and harms of a medication and the approach to managing a chronic condition may change with aging and cognitive impairment. And the clinician is focusing on an adverse effect of medications that's particularly important to older adults, that of falls. So here the clinician says, normally in diabetes, we think about the risk of kidney disease and the risk of eye disease, but as we get older, the risk of a low sugar reaction is actually more important. You could fall, you could hit your head and break your hip. And then finally, in this example, the clinician is explicitly recognizing the uncertainty of the available evidence for older adults with cognitive impairment and competing health risks. And so he's thereby acknowledging that this is a preference-sensitive decision. So the clinician says, the problem with blood thinners is that if you fall and injure yourself, you can bleed, but it's a risk versus a benefit. There are people who are on 3 and 4 of these medicines. Now, they're at great risk to have bleeding, but they're also at great risk to have blood clots. The reason why I have a lot of gray hair is that it's a constant battle. So our next theme was clinician strategies for facilitating patient and caregiver engagement around medication decisions. And we found that clinicians used a variety of approaches to develop partnerships with patients and caregivers and to invite shared decision-making about medication use. So these strategies included reassuring patients that the clinician will not withdraw appropriate care, reassuring patients that the clinician will monitor closely for negative consequences resulting from deprescribing, and finally explicitly eliciting the patient's or caregiver's perspective on a medication change. So in this example, the clinician is reassuring the patient that he will approach medication decisions cautiously and he won't withdraw appropriate care. And so he says, this is my first time meeting you, and I don't want to change everything for you right at once. I want to get to know you a little bit more and then work together on minimizing your medicines. Understanding that I need to take care of your neuropathy, I need to make sure you're sleeping okay, and I need to make sure your blood pressure is okay. So I will not sacrifice what needs to be done, but I will try to minimize the amount of medicine that we use for it. In this next example, the clinician is reassuring the patient that he will monitor closely for any negative consequences that may result from deprescribing. So here the clinician says, you don't need amlodipine for your blood pressure. Your blood pressure is doing fine even on a lower dose, and I think you're going to do fine without it. We'll check you again down the short road. And then finally, in this example, the clinician is explicitly eliciting the patient's or caregiver's perspective on the medication change. So the clinician says, this falling is a new event. So now that we have a new event that's happening, we need to modify. Down the road, if I want to take you off of the amitriptyline and replace it with something else for your neuropathy, would you be okay with that? And the patient and caregiver responded really positively to that. So finally, we found that clinicians often had to balance the principles of optimal prescribing against other considerations that in many cases outweighed them. Factors that complicated optimal prescribing included the following. So often patients or caregivers' expectations of receiving a prescription for a bothersome symptom influenced clinicians' prescribing decisions in spite of good intentions to deprescribe. At times, there was also discordance between clinicians' recommendations to deprescribe and patient or caregiver preferences. In addition, clinicians sometimes seem to have difficulty balancing the traditional disease-based approach to care for non-dementia illnesses with quality of life and treatment burden. Optimal prescribing was also complicated by the need to respond to distressing behavioral and psychological symptoms of dementia, and particularly to help caregivers deal with these symptoms. And then finally, we found that clinicians who were under enormous time pressure during these visits frequently had their attention diverted by the sheer complexity of patients' health problems, as well as things like missing records and technical or logistical issues, and this left little time for discussion about optimal prescribing. Even sometimes when patients or caregivers explicitly mention concerns about treatment burden or medication appropriateness. So again, for the sake of time, I'm going to present 3 of these sub-themes with representative quotes. So this is an example in which the patient's expectations seem to influence the clinician's prescribing behavior. So the patient started out by saying, I need something now for my bladder. And the clinician says, well, the medicines that we use to slow the bladder down kind of have side effects. The side effects can be things like dry mouth, but they can also be dizziness. We have to be very, very careful. And then the clinician stopped mid-sentence. So he had started out by hesitating because of the bladder antimuscarinics, well-documented central nervous system side effects, particularly for people with cognitive impairment, and he then sort of changes course and recalls a positive experience with another patient, and he says, Well, I have a patient about your age, actually, who had a similar problem. She was really miserable, and I mean, we were able to put her on a very small dose of a medicine, and she's like a new woman. I've got to tell you, it's really incredible. And he then wrote a prescription for oxybutynin, and he said, I wouldn't give it to you if I didn't think it wasn't safe. I just want to be clear that it can have these subtle effects on you. So next is an example of discordance between the clinician's recommendations and caregiver preferences. So this clinician started the visit by saying, let's trim any medications that we can trim for this 100-year-old patient with a mini-mental score of 9. And then the caregiver described the patient's recent hospitalization. And the caregiver says, so this young doctor comes in. It was the cholesterol medicine, the atorvastatin. I said, why does he have to discontinue that? Oh, well, studies show that after the age of 70, it's not very effective. And the caregiver says, well, I bet you we could find studies that show that it is. And then lastly, in this example, this 85-year-old patient was explicitly raising the idea of treatment burden, and the clinician seemed to have difficulty following up on the cue, perhaps because they weren't expecting to hear it or because they had difficulty knowing when and how to shift away from the disease-based approach to care. So the patient says, I take 5 pills in the morning, 9 after I eat, and 5 more in the evening at bedtime. That's 19 pills. And so the clinician didn't address that directly, and then later on ended the visit by saying, so your diabetes was perfect. You were at 5.8, so we don't need to do anything different. I'll just see you back in 6 months for your complete physical, okay? So in conclusion, we were encouraged to find many examples of clinicians attempting to initiate discussions of deprescribing, but we also found these examples that showed how complicated deprescribing is. Dementia is extremely challenging to care for, and we're still practicing medicine in a disease-based world. Taking a medication often seems easier than implementing a behavioral change, and we also sometimes need to treat caregivers in addition to the patients. So our research agenda is now going to focus on testing these communication strategies that we identified with patients and caregivers to understand their preferences for how clinicians should talk with them about optimizing prescribing. And it will also be important to continue building the evidence base related to competing risks. So for example, we don't yet know the best way to manage hypertension in people with dementia. And it will also be important to gather more evidence related to the outcomes of de-intensification or deprescribing, as this will further inform medication decisions for people with cognitive impairment and dementia. And so with that, thank you very much for listening, and I'm happy to answer any questions.
Thank you to both of our presenters, Mayra and Ariel. So interesting. We so much appreciate it. As a reminder, now is the time for any questions that you might have for our speakers. Again, as a reminder, feel free to click on the Q&A tab on the right side of the screen and type in the Q&A box. And I think I'll start it out with a question for Ariel. I'm wondering, you discussed patient and clinician issues that can stand in the way of moving forward on deprescribing. Can you comment on any barriers within the healthcare system?
Yeah, so I think, one barrier just did seem to be time. We counted, and in some visits, and these were actually in many cases longer visits than many people have. So sometimes half-hour visits where people were, still addressing 19 different topics that ranged from, acute findings on physical exam to caregivers' questions about insurance, and the clinician was, you could hear them, trying to track down lab results and records. And so I think just that burden of time and how to manage all of that complexity during visits. And then I think also just communication between different people involved in the patient's care is also a barrier. So there were visits where these primary care clinicians said, like, I'm not so sure that you should be on this dose of, whatever cardiac medicine it was. I'd like to talk with your cardiologist. And then, you could tell that it was really difficult for them to actually have the ability to communicate with the specialists, to reach them and to get a hold of the right person. And so I think those are two big issues.
When you think of the population in your study, you had excluded those that didn't have a care partner that attended the visit. What percent of patients are coming without a care partner, and what kind of unique obstacles does that kind of throw into the mix when thinking of deprescribing?
Yeah, so that's a really good question. So I'm not actually sure off the top of my head what percent don't have a caregiver, but I do know actually from another study we did, because this study, so it's the same page trial really was focused on people with caregivers and improving that triadic communication. But I know from another study we did where we interviewed clinicians about barriers to deprescribing for these patients, that if patients don't come with a caregiver, or another common scenario where they come with a different caregiver who might not be the primary person who's at home with them, or they come with different caregivers each visit, I think, so that is, that really complicates things, because then the clinicians did really say that they had, in the interview study we did, they really had to know about the caregivers' knowledge and skills and how available they were, for example. So when they wanted to get people off of bladder antimuscarinics and implement behavioral strategies, they can't do that if they don't know that the caregiver is going to be able to help, and so help with, things like scheduled toileting.
Yeah, that can be a big problem.
Mm-hmm.
At HealthPartners, we use pharmacists to do medication management visits with some of our patients with dementia. I'm just wondering if you had unlimited resources, all the money in the world, what would you do? What would you think the best approach would be to really help patients with dementia and their families deal with this?
Yeah, and so I think in health systems like where there are pharmacists who can talk with patients and family members and help navigate some of these decisions about which medications are appropriate, and I think that is a really valuable resource. That was another thing that came up in the interview study that we did, where clinicians who did have access to interdisciplinary specialties, so not only pharmacists, but also, for example, continence nurses who could counsel people on behavioral strategies, or things like dementia care navigators who can counsel people about dealing with challenging behavioral symptoms. So all of those kind of interdisciplinary resources, to have access to those, I think would really help people avoid some medications that they may be taking. So I think that would probably be, that's just one thing that comes to mind, I think.
So I'm not seeing any other questions come through. I don't know, Catherine, if you're seeing any, let me know. Otherwise, I think I might ask Mayra if you'd be willing to comment. Now, you were a pilot award winner for your work, and you had a large team of mentors that helped you with your research study, and congratulations on your recent publication. I'm wondering if you could comment on did you have any surprises along the way or learnings that you could share with other junior investigators as they're sort of navigating the mentor-mentee relationship and working on a project that's as complicated as the one you entered into?
Yeah, I think, for me at least, it was a great experience. I didn't have any experience before with data sets as large as the one that I used, the Cardiovascular Research Network. And even though, we have, our group was also Alan Go and his team in California, it was a great experience because I feel like I learned a lot, not only for this group in California, but also dealing with a large data set. It's wonderful to have a lot of, patients with heart failure, but also, it's good to know where to go with your questions. So for me, at least, was a great experience, and actually it helped me to start building the next steps for my career. This was just a pilot study. I have to answer, a few questions in just 1 year, but open the door for other opportunities. And a few months ago was submitted an R01, and is the next step for expanding a little bit more our work and not only looking in patients with heart failure and how to assess multimorbidity burden, but also looking into how the patients with heart failure and multiple chronic conditions are treated, and how these treatments affect outcomes. So it's a great opportunity. I invite anyone that can apply to this pilot site to do it, because it opens a lot of doors, and it's a great opportunity to learn, from people from different places with different experiences. So it was really wonderful.
Great, thank you for sharing that. I do have one question, this quick question that came in that could go to either presenter. The question is, what do you think about multimorbidities among older minority populations? What are the unique barriers or knowledge gaps, and what do we know and what needs to be done?
That's a great question. I don't know about Ariel. We have some minorities, but it's always a challenge because, usually access to care is a problem. So I feel like, it's an important barrier. Older adults are not included in these studies, so we have a challenge to try to treat these patients with multiple chronic conditions and heart failure, and we don't have guidelines to treat them. But, this is even worse when we have minorities that we don't have included in clinical trials. So it's a lot of information that we need to gather, and I think it's a lot of opportunities to develop new clinical trials where we can, or maybe pragmatic trials, where we can include patients with multiple chronic conditions from different minorities and different ethnicities to try to understand a little bit more all these challenges that we, have every day when we're treating with these patients.
Yeah, definitely. And Ariel, you had a fairly diverse patient population in your study. Was it 42% non-white?
Right, and I'm actually involved with another study now where a deprescribing study involving specifically healthcare disparities and minority populations. So in terms of deprescribing, which is my interest, I think that there are a lot of unique challenges. For example, things that we know from other areas of medicine, like challenges in terms of trust in the healthcare system, that may be barriers additional barriers to deprescribing, but there's also a lot of potential resources or facilitators of deprescribing that we might be able to tap into that are unique to minority populations. Such as community or family or neighborhood sort of engagement. So, people get their information from different places, not just from doctors necessarily about medications. So I think that, there may be unique barriers, but also positive things that we just need to know more about, I think.
Great. Thank you both so much, and thanks to everyone for attending today's webinar. The recording for the webinar will be posted soon on the Aging website. And as you sign off, you're going to be prompted to complete a very brief survey. We'd really appreciate your input. It will take just a few seconds to give us your feedback. Again, thank you so much to everyone, and have a great rest of your day.
Oh, there's one more question that came in, if folks have a minute to try to interrupt Leah. Someone asked, what is the clinical implication of your results? And I think this is directed towards Mayra.
Okay. Yeah, I think the impact is just try to see how multiple morbidity burden impact outcomes, and how also to decide or prioritize what populations are at a higher risk. So if you have a group of patients that have worse outcomes than the others, then maybe we need to screen patients better. And I think the whole idea of this pilot study was trying to identify populations at risk and maybe include these populations in larger data, larger studies, larger clinical trials, and try to see how these patients respond to treatment and how these treatments affect outcomes. So I think it's just a little step into the direction of future and larger studies where these patients that are usually not included in clinical trials can be helped, because it's a big challenge how to deal with these patients, but we don't have any instruments or any tools to deal with this dilemma, how to treat these patients. So it's just a little step in trying to identify groups at risk and maybe including these groups and minorities into larger studies or larger clinical trials to help identify outcomes and improve the healthcare of these patients.
Great, thank you. And we have another question from Heather. It sounds like she's not able to communicate through the chat, but she's asked, in Ariel, in the patient case that you began with, the patient had macular degeneration as one of the problems on your list. Have either of you considered sensory impairments and their role in morbidity burden?
So I haven't specifically, although it's super interesting and yeah, I mean, would be something great to look into more in terms of how people are specific, like, you know, certain medications, for example, are more challenging for people to use and cause more treatment burden and probably less benefit or more risk of adverse events with sensory impairment, like vision impairment. So yeah, I mean, I think that would be a great topic. I haven't personally explored it yet.
And Mayra, did you consider sensory impairments in your work?
We have in the pilot study, we have hearing impairment and visual impairment included, but they were just ICD-9 codes, so it was very broad, and it could be anything like, I don't know, wearing glasses. So it's what we have available in the data set. So we thought it was important, and it's an impairment and something that can affect outcomes. So we included those ICD codes that identify visual impairment and hearing impairment. But as I said, I mean, it's a broad approach, and I will really like to have something that is more refined and maybe see how these sensory impairments affect or outcomes as a separate covariate, as a separate analysis. It would be great to have it.
Yes. A question for Ariel. Are there any written materials or resources or tools that are available to help facilitate deprescribing in older patients with dementia or with their caregivers?
No, so that is exactly what we're working on. So I'm involved in a couple of studies. One is trying to create tools both for clinicians to help give them sort of sample language to kind of start out these discussions, as well as a tool directly mailed to patients and caregivers to help sort of prime them to think about the fact that deprescribing is even an option, and that the choice to take a medicine, to prescribe a medicine, to continue a medicine, to stop a medicine, all of those are active choices that that it may not have occurred to patients and families to think that way. So we are working on developing tools like that. And then also the subsequent study that I talked about, where we're trying to actually see what phrases patients and caregivers, what phrases resonate with them about deprescribing, will hopefully help lead to other kinds of tools as well.
Oh, that's great. You'll have to keep us in the loop. We'd love to help disseminate those. I think a lot of clinicians would appreciate having that.
Yeah.
All right, last call for questions. Okay. Well, thank you so much for this stimulating conversation, and again for your presentations. You'll see on the slides the link to our Aging Initiative website. And if you have any questions, you can give Catherine an email. And again, we'd really appreciate your feedback about this webinar. And I hope everyone enjoys, hopefully you have beautiful weather wherever you're calling in from, and has an amazing day. Thank you so much.
Thank you.
Thank you.